Hello and welcome to this webinar. Today we'll be talking about COVID-19, especially in regard to health disparities and patient education. Presenting today will be myself. My name is Linda Barman. I'm a clinical assistant professor at the Stanford University School of Medicine. I also help to run our express care clinics and our Crown Clinic, where we take care of our outpatients with COVID-19. And I also help to start our COVID-19 drive-through testing. I'll be joined by one of my colleagues, Alejandro Toledo. Alejandro is a current student at UC Berkeley in cell and molecular biology. I worked with him during the Stanford Summer Community College pre-medical program, and he'll be talking as well. So our goals for today, I want you to leave this webinar with some appreciation and the awareness of the significant disparities we see in COVID-19, rates and deaths, some tactics to combat these disparities in your communities, appreciation of the importance of patient education, and some knowledge of patient education material you may want to consider covering with your communities and patients. So first of all, Alejandro is going to be speaking for a few moments about a patient he saw.
Hello, everyone. My name is Alejandro Toledo, a current student at UC Berkeley volunteering at a COVID-19 site in the city of East Palo Alto. I am an alumni from a Stanford pre-medical program that took place this summer, where I was introduced to Dr. Barman, and since then we have been collaborating over COVID-19 issues. Before I introduce our testing site, I would like to start the talk with Maria's case to anchor and humanize the discussion. The case I have here is meant to bring awareness about the type of patients that come in to our testing centers. I broke down my encounter with our patient named Maria into 5 components as seen on the screen. So here we have Maria G, who comes into our testing center with several symptoms such as a fever and a cough, along with her 3 kids in the back seat with no air conditioning during a heat wave. Here you can see a hardworking single mom with no childcare. Of course, I did not know this from the start, and so I had to conversate with her when she drove up. So I want to emphasize that asking questions and hearing each individual story is important because not everyone has the same backstory to why they want to be tested. Having said so, Maria explained to me that her daughter, who works for IKEA, which is actually across the street from that day's testing site, had tested positive the day before, and therefore this allowed me to understand why she could be positive and why she drove up to the site. Towards the end of our conversation, she was panicking about the possibility of testing positive, and therefore I had to ensure her that she has someone who can hear her out completely and provide relief while she is at our site. In other words, it is crucial to directly acknowledge the patient and their fears and give them reassurance for their individual situation.
So Alejandro, thank you very much for telling us about Maria. Maria is a real patient. The challenges she faces are faced by many of our patients. And I always like to start with a case to help us humanize and ground the discussion and remind us that we're talking about individuals. Health disparities, as many of you are aware, there's significant evidence showing significant disparities in COVID infection-19 rates and deaths among different populations. I'm going to go over quickly. There's many studies we could cover, but 2 studies. First was published in the New England Journal, looking at Louisiana, which suffered severely at the beginning of the pandemic. At Ochsner Health, they found that almost 77% of the patients who were hospitalized with COVID-19 were Black, despite comprising only 31% of the local population. One thing I want to emphasize that they found was that Black race itself was not associated with higher mortality rates after adjusting for differences in socioeconomic and clinical characteristics. Early on in the pandemic, some people thought that there were inherent genetic or biochemical reasons why different races were affected differently. We found out this is not true. All of the differences in outcomes can be explained by other things, and many of them we can't address. The CDC collects data on COVID infection cases, including, if reported, their reported race and ethnicity, and found that across the US, 33% of COVID cases were in patients who identified as Hispanic, 22% in Black, and 1.3% in Native Americans. All of these being disproportionately higher than expected given their proportion of the population. I'm going to bring it a little bit closer to home, looking at California. This is on, you can look it up yourself, the COVID-19.com race dashboard. Goes by states. This was at the beginning of November. Obviously, the rates will change. You can look it up yourself. In California, Latinos make up 39% of the population, but represented 61% of the cases of COVID-19, dramatically higher than we would expect. Interestingly, despite comprising 61% of the cases, Latinos comprised only 49% of the deaths. While still higher than we would expect given the representation of the population, this is lower than we would expect given the percentage of cases. The reason is not clear at this point. Some people think it may be due to patients being maybe of a younger age, but it's not yet clear. We see the opposite pattern in whites. Whites make up a similar percentage of the population in California as Latino, but represent only 17% of the COVID-19 cases in the United States, in California. The rates in other ethnic groups are too low at this time to draw strong conclusions. There are many causes of the health disparities that we see in COVID-19. And again, these are non-biological. It has nothing inherently to do with your genetics if you're from a certain race. This means that many of these are things that we can address. Occupation and housing play a significant role in your risk of getting COVID-19. I'm going to go into detail on those in later slides. Access to healthcare is also critical. And there's many things that play into this. First, obviously, we think about health insurance. We know the patients that do not have health insurance are more likely to delay seeking care until they're quite ill. Location is also important. If you can have the best insurance in the world, if you live in a rural area with no nearby healthcare and no access to transportation, you won't be able to access it. Even in an urban setting, is there a clinic in your neighborhood? Is it located close to public transportation? Do you have access to transportation? Can you get there? Language is essential as well. We know that many languages are spoken in California. And you can have the best public health campaign in the world and have billboards everywhere, signs everywhere, and all the buses. But if they're not in the languages that your patients speak, it's not going to do any good. Literacy is critical as well. And this is something I think we don't often address in healthcare. I myself, when I was working at the county hospital, did an informal survey of my patients, asking them simply, can you read? And I was shocked to find that 40% of my patients admitted they had limited to no literacy. In my 20 years of practicing as a physician, I've never once had a patient tell me, Dr. Barman, I can't read. All these handouts you've been giving to me, they don't work for me. We have to assume that a significant part of our population is going to have difficulty with our written materials and address that from the beginning. And I'm going to show you some examples later on. Trust is also a big factor. There is mistrust among many populations of the healthcare system due to historical and current discrimination and racism. Moving on to the right side, we know that socioeconomic status is strongly linked to healthcare outcomes in all fields. Legal status, unfortunately, is also important. Many of our patients are afraid to seek care or get tested for fear that they may be deported. Race and ethnicity is also important. Racism itself makes people sick. And also there's evidence that when the patients and the healthcare workers are from different backgrounds, healthcare outcomes are not as good as when they're from similar backgrounds. One study was done looking at comparing African-American men whose primary care doctors were also African-American men or not. The patients who had primary care doctors who were more similar to themselves had improved rates of cancer screening and better blood pressure control. And we can address this by trying to increase the diversity of our healthcare workforce. I want to talk specifically about racism. There's very interesting research out there that strongly shows that racism itself makes people sick. One study interviewed people and asked about their experiences of experiencing racism. Higher rates of racism were associated with worse mental health outcomes, health status, and physical health outcomes. Another study showed specifically that experiencing racism in life increases your level of inflammation. This happens even if you experience racism in your youth, predicts worse outcome in your adult years. And what I want to stress is that effect of racism was stronger than the effect of other risk factors we always think about, such as diet, exercise, smoking, and low socioeconomic status on people's health. We always, as healthcare workers, talk with people about their diet, their exercise, and don't smoke. But we need to realize that racism is equally or more harmful to their health, and we need to work on that. Occupation. Occupation, the work that you do, has a strong influence on your chance of getting COVID-19 and how you'll do for multiple reasons. In the beginning, I thought it was if you work in a hospital, if you work in a nursing home, you're going to be exposed more. And we know there are outbreaks in meatpacking plants. But I've learned that there's much more nuanced than that. If you have paid time off of work you're more likely to stay home when you get sick. If you don't, if you only get paid when you show up at work, you and your coworkers might be more likely to go if you have a little cough, a little sniffle, because you can't afford to stay home and not get paid. If you're allowed to take time off to go see the doctor, you can go to the doctor and get a test. In addition, if you can work from home, if you're a software engineer, you can do your work from home. You can stay at home safely behind your computer versus essential workers. I call this why I sometimes retest nannies. It is important to know what occupations our patients have and how that specifically impacts them in regards to their COVID-19. This example is that in general, we do not encourage retesting for COVID to see if someone's cleared the infection. If you've tested positive, we follow the Santa Clara County Public Health Guidelines, which is that if you're generally healthy, we consider you not contagious if it's been 10 days since your symptom onset and at least 3 days since your last fever. I've had many patients coming to me saying, "Doctor, I need a test again so I can go back to work." And I try to talk them out of it. You don't need it. You don't need it. And I found out that many of my patients were working as nannies and were working in the informal economy. They were being paid cash. They didn't have paid time off. And I could talk to them until I was blue in the face that they don't need a retest, but their employers wouldn't let them come back to work until they had a negative test, and they wouldn't get paid until they went back to work. So I retest them now if they need it. But that's an example of why it's important to know what jobs our patients have and how that impacts them so we can better take care of them. Housing. Housing is critically important as well. And again, similar to occupation, it's very complicated. At the beginning, I thought housing is you're homeless or you're housed. And that's kind of how I broke it down. And my patients, by talking with them and the questions they asked me, I've realized how nuanced this is. If you're living in a private home in Atherton, it's a lot different than if you're living in an apartment building in an urban area. Things you want to know about. Can you go straight in your home? Or do you share an entryway? Are you going through a lobby? Do you have to share parking with other people? I now ask my patients about laundry. I did that because I had a patient ask me, he said, "Doctor, I need a work note, or I need a note to show my landlord. My landlord won't let me use the laundry room because he says I'm contagious." Many of our patients don't have laundry in each apartment unit. And I told him, I said, "I'm so sorry, but your landlord is right. You can't use the laundry room while you're contagious." So it's an issue I address with all my patients now up front. It is critically important. So one of the best things we can do with our patients with COVID-19, since we don't have a great treatment yet, is preventing them from giving it to other people. That's probably the most important thing we can do at this point. In order to do that, you need to know in detail who they live with. How many people are in your house? How old are they? Are they at high risk? Is there a pregnant woman? Is there a newborn? Obviously, these are really personal questions to ask people. So I always start out by explaining to people why I'm asking these things. I want to find out who you're living with so we can keep your family safe. And in my experience in taking care of patients with COVID-19, that is their primary concern. And they will go to the ends of the earth to keep their family members safe. I have one patient who wore a mask 24 hours a day, even sleeping in a mask, so she wanted to give it to her children. And an adult son who would climb out of a window and use a camp toilet in the backyard so that he wouldn't get his adult parents in the house sick because they only had one bathroom. Air quality is important to know about. We know with the wildfires, that was a big issue. Air quality in general is worse in some neighborhoods than others and increases your risk of respiratory disease. Also, older buildings are more likely to have poor air filtration and worse air quality than newer buildings. I always ask people if they have access to outdoors, and I'll talk about that a little bit later on in the patient education. Obviously, we do want to know if patients are homeless. Some counties, Santa Clara County included, do have resources to connect people to housing and put people up in hotels if they're COVID-19 positive. But we need to know if they are homeless so we can help them access that resource. Equally important is knowing if they're on the verge of becoming homeless. We have many patients who are facing eviction because they've lost their jobs, their hours have been decreased. There are legal protections to prevent people from being evicted during COVID-19 crisis, but a lot of people don't know how to access those. So we need to ask the patients about this specifically so we can hook them up with resources. We want to know if they're in what we call a congregate living setting, which is any of the following. That is higher risk. And I want to know, how are you going to access healthcare if you need it? I'm talking to you on the phone, I'm doing a video visit, you got diagnosed. What are we going to do if you get worse? I'm happy to see you in clinic. I got my PPE. I work at the COVID-19 clinic. If we want to check on your breathing, we can bring you in. But how are you going to get here? I have many patients that don't have their own car and rely on public transportation, and I don't want them getting on a bus if they're contagious. So that's something we need to realize about and individualize for each patient. So we're going to talk now. Alejandro is going to tell you about the testing programs he works with in East Palo Alto. I'm going to contrast that a little bit to the Stanford testing program. And we're going to move on to how we can address health inequities and patient education. Thank you very much. Alejandro, it's your turn.
So now a little bit about who we are. The COVID-19 site is run from volunteers like myself under the supervision of a city employed director. The site is funded through the partnership of the San Mateo County and the city of East Palo Alto. Our site is composed of 2 providers, which allows us to have more testing kits and therefore increase our outreach to members of the community and elsewhere. On the same note, by having 2 providers, it allows us to have a reserved amount for just the residents of East Palo Alto to ensure that they always have tests available from our first provider, and the second provider is for all people from every city. Our site tries to optimize its availability by not having a hard timeline of when we close, but trying to go until supply is out because we know that patients appreciate flexibility. We also provide 4 languages: English, Spanish, Samoan, and Tongan. We believe in the statement, more languages gains more connections. Lastly is that we allow walk-ups in addition to drive-ins. By offering these 2 options to your patients, it maximizes ability to get people tested because not everyone drives, but mostly everyone walks. So how do we reach everyone? There is 6 elements that we integrated into our site to decrease the gap between testing in our city. So first, we make it tech-friendly. And by that, I mean that no one needs an appointment to get tested. They drive in or walk up and get registered on site and tested within minutes with no email required. Our city decided to create numerous pre-generated emails in which any person without an email can receive a card that includes their unique email address and password to later view their results. This saves time and allows more people to get tested. Second is that we're located at markets, YMCAs, churches, homeless shelters, busy streets, and apartments. By having more than one location, we increase accessibility since some cannot drive or it might not be convenient. I encourage everyone to think about not just having a fixed location, but going out of the box. As far as citizenship, none is required because anyone can get COVID. We sometimes provide snacks, which brings in new patients, such as homeless. We set up banners at the freeway entrance, local gas stations, and place signs on crosswalks that are very busy in different languages to bring awareness. Our site opens from 8 a.m. and closes at 8 p.m. at 2 different locations to accommodate different work schedules because not everyone can take time off from work to get tested. These 6 factors I've mentioned to you prove to be very useful at our testing center, and I encourage all to try to implement similar mechanisms in accordance to your surroundings. We work with 2 different companies that are a bit different, yet it allows us to reach out to more patients. The city's provided tests from 2 companies, Curative on the left, Project Baseline on the right of the slide. Curative supplies 70 oral tests for which residents from the community with ID show their address, either a California ID, driver license, or any other form of ID with their picture on it. If no ID, we still take them given that they provide a valid East Palo Alto address. Technology allows us to get on-site registration in 5 minutes and no smartphone is required from patients, since with our iPads, we can get them registered in a minute and finish their testing in 5 minutes. Now for the second company, Project Baseline, it handles hundreds of nasal tests for all, but we can only register folks since the test is administered by only nurses and Curative is run by volunteers like myself. Therefore, by having a volunteer-run site under the care of the different provider, it amplifies the quantity of tests in the city, but also reduces saturation of appointments for one provider. So 2 providers and their appropriate mechanisms amplifies community outreach. Residing in East Palo Alto brings a variety of individuals from various ethnic backgrounds, and therefore the site I represent tries to recruit volunteers who speak the same language as the patients coming in. So it is for that reason that we are able to provide testing in 4 languages: English, Spanish, Samoan, and Tongan. Educating ourselves on the languages spoken by the community allows us greater outreach. So to understand a language you should probably implement in your city, I recommend using a website that I found very useful called data.census.gov. And it allows you to explore census data. Once you are on the page, there is a search bar to the database. So for my city, I typed in East Palo Alto languages, and it provided me data for major languages spoken in the homes in my community. and they're given percentages along with other useful information. Researching these statistics, I came to find 27.6% of residents have English as their primary language. Spanish is spoken by 58.49% of the population. And following these two languages, Asian and Pacific Island languages make up another portion as seen on the slides. On the bottom left, we have 5% Tongan, on the bottom right, 5% Samoan. So it is for that reason that we provide these 4 languages, to expand our diversity. Lastly, I would talk about the use of our flyers and how they are unique to helping disparities and education in itself. If we inform patients in various languages that they speak about the statistics in their neighborhoods, streets, and city, it will raise awareness about the issue. For your communities, you can investigate the following components as I did: positive testing rate in percentage form, which is easy to read, compare the rate of COVID-19 to the county average, deaths, and incorporating visuals that represent CDC guidelines such as wearing masks, washing your hands, social distancing, and etc. Although this set of information might seem redundant to us who are concentrating on the pandemic, to others it might not be a topic they are well informed upon, and therefore we have to not assume that everyone knows the quote-unquote basics. By having a brochure that is laminated and in color, it increases the chance that they do not throw it away and that they actually want to read it. We made the flyer in this manner because some of our residents have limited reading skills, and reading is a barrier to accessing the message. Also, we want a clear, concise message since we are looking at focusing on one or another key topics for even more precisely focused outreach. Next is another slide we hand out to patients. It is titled, "Are you experiencing COVID-19 symptoms?" We break down the don't have symptoms bracket into 3 subsections for different scenarios. Let's say you already have health coverage but simply want to speak with a nurse directly, then we provide 2 solutions. Or if you do not want to speak to a nurse but want to get enrolled in health coverage, then 3 pathways to doing so is listed. These flyers are in English and Spanish as seen on the right of the slide, and they all contain links as well as phone numbers for people who do not have access to the internet. So as the flyer indicates at the very top, am I experiencing COVID-19 symptoms? It is the big question a lot of individuals ask themselves. So having a plan to this question is crucial to ensure an adequate response and direct solution. In all of this, I want to encourage others to be able to create easy to follow flyers that are visually pleasing and straight to the point. In other words, something that a teenager can easily follow since COVID-19 affects all people from all backgrounds. So takeaways. Number 1, ask questions on why they are here. So yeah, get to know what brings them in. And if they think they have possibly been exposed, you can make the connection with them and talk to them and make sure that their medical treatment is even more effective. The second point is to educate them while they're waiting to be registered. Show them flyers with resources that are for their specific city, because the best way to address these health disparities is educating them on the spot, since once they leave your site, you may never see them again, and therefore you want to optimize your great impact. Lastly is ensuring they leave better than they came in. So as they leave my site that I volunteer at, they're given various flyers about resources about the effects of COVID-19, but also how to address them, such as rent support, health insurance, and hotel vouchers, which will in turn help far beyond we can imagine. Thank you for your time. Now I will transition to Dr. Barman, who will talk about the health disparities and patient education.
Okay, Alejandro, thank you for sharing that with us. I'm going to talk a little bit about how we do things in Palo Alto for testing and move on to patient education. So this is our COVID-19 testing site on the Stanford campus. So a bunch of my colleagues there spelling out the word COVID. So I'm just going to go really quickly. Stanford, our testing is on healthcare campuses on private property, not in the public. It is by appointment and drive-through. You do not need insurance. Our employees, Stanford is a pretty diverse employee population. 58% of employees at Stanford are female and 57% are ethnic minorities. So we're relatively diverse, but we know California itself is even more so. So testing, I'm going to address testing and health disparities specifically. And I think it's really important to realize that one way of testing is not going to meet all patients' needs. Not everyone has an iPhone. You can't just use an app. I get a little frustrated because I live in Silicon Valley. Obviously, people are always coming up to me with high tech. Oh, we can have an app for this. We're going to do this. We're going to do a website. And I keep saying, okay, not everyone has an iPhone. Not everyone has a smartphone. Not everyone has access to the internet. Even if patients have a smartphone, not everyone has unlimited data plans. A lot of our patients do pay as you go. They have the money, as much money as they have. They buy a data card for that month. When the data is up, they're done. Obviously, people have different levels of comfort with technology. I would encourage you, though, not to assume that older people can't use technology and younger people can. I have 92-year-old patients who email me, and I am absolutely terrible at technology. Therefore, I think with any outreach materials or information on testing, it's essential to include phone numbers people can call, as well as having numbers for websites or apps. Most people, even if they don't have access to the internet, can call a number and get an appointment, but it's essential we have that. Transportation is essential as well. Not everyone has a private car. If you have a testing center you're running, put on all the information on how to get there. Not just the address, because not everyone has unlimited data to look at maps online. Put on directions, landmarks, and especially how to get there in public transport. What are the closest bus stops that they can use? Remember, think about some of our patients have limited mobility. We may have patients that are disabled. It's hard for them to get out of their car. Make sure your site is accessible to the disabled. If patients can't walk there, can't get out of their car, do you have people that can test them in their car? Try to, as much as you can, accommodate people on bikes and pedestrians. Again, not everyone has a private vehicle. It's also important to keep traffic safety in mind. We don't want to have pedestrians waiting in line with a bunch of cars. I tell people at my drive-through testing site when I'm training them, I say the most dangerous thing you're going to do today is not that you're going to get COVID, is that you're on your feet in a parking lot and there's a lot of cars around. My biggest fear is you're going to get hit by a car. So if you have pedestrians coming in, try to have a separate line for them so they're not waiting with cars. I think a great thing that Alejandro's site does is they have different kinds of tests. The nasopharyngeal, everyone got that in the beginning. We now have options such as the nasal test or the oral test. A lot of young children can't really tolerate the nasopharyngeal, but also we have people with autism, developmentally delayed adults, people who had facial surgery. By offering different kinds of testing, you make it accessible to more people. I think Alejandro does a great job too. He helps people with registration. You don't have to go online and sign up ahead of time. If you don't have access to the internet, you can't do that. You can come on in and they're going to help you quickly get registered. Having hours outside of 9 to 5 is essential as well. Like we talked about with occupation, not everyone can take time off of work to come in and get tested. If you have hours on the weekends or in the evenings, that makes testing available to a larger part of the population. I think also we talked about a little bit earlier that having a healthcare workforce that's discordant from our patients does not do them a good service. So think about expanding your workforce so that it better matches the community you're serving. Not everyone working in a COVID-19 drive-through testing site has to be an RN. Alejandro's site has recruited volunteers to help out. You can also have non-traditional workers. When you widen the base that you're pulling from, you can make sure that your health force better matches the community you're serving. So I'm going to talk a little bit about what I've learned and what we've learned. Stanford Crown Clinic, we call it the Crown Clinic. It's where we take care of our patients who've tested positive for COVID-19. Most of them do not get hospitalized. We take care of everyone as an outpatient, try to support them and keep them out of the hospital. We've taken care of over 700 patients at this point. We've learned a lot. We learned early on that a lot of our patients weren't really comfortable coming to Stanford. They were new to us. They were intimidated. They were more comfortable going to their home community clinics in their own neighborhood where they were more familiar with the setting. So I reached out, made a bunch of phone calls and emails, and met a lot of people at the local community clinics. And now we have an open line of communication. Someone tests positive at Stanford, I let their primary doctor know at the community clinic, figure out how to support them. We can't live in our own little silos anymore. We need to all work together. In the beginning, we did all high tech. Well, not all high tech, but a lot of high tech. We emailed people surveys. We wanted all video visits, all telehealth. We had our webcams up. And a lot of our patients, the video visits didn't work for them. They wanted to do it by phone. And so now we do that. You want to do, I love seeing you on video. I like seeing your face. But if you don't know how to use the webcam, if you don't have your data plan isn't big enough, you're not comfortable doing that, we can do a phone. We also do offer weekend hours. We don't want patients shouldn't be working if they test positive for COVID, but having access over hours makes it more accessible to everyone. Interpreters are essential. And this is something, I realize a lot of things I say sound kind of obvious, but it's not just having an interpreter somewhere or asking someone what language they speak. You need to have the expectation being that every patient on intake will be asked what language they prefer. And every time you contact that patient, you're going to have an interpreter of that language already on the line, ready to go. This is easier said sometimes than done. I know a lot of times we're in a hurry. It takes a while to get an interpreter, but this is hugely important. This was struck home to me by a conversation I had with a patient, which was kind of heartbreaking. She had recently been discharged from another hospital after being hospitalized for COVID-19 and was sent home with oxygen. She was following up with us at the Crown Clinic to see how she was doing. She didn't know how much oxygen she was supposed to be on. She didn't know how she's supposed to check her oxygen or what she's supposed to do. She told me that she felt like the nurses in the hospital she was at were angry at her for not speaking English and got irritated when she asked too many questions. She was ashamed and didn't ask the questions she needed to ask and didn't get the information she needed. We have made it clear to everyone working in our Crown Clinic, interpreters. If you can't communicate with a patient, you're not doing them any good. So we have on all of our computers, there's Post-it notes with all the interpreter phone numbers. The main Stanford one, if you need someone for other languages, 24/7, on all the walls, on all the Post-it boards, that really strikes home to people. This is what we do. And we've gotten feedback from patients that that's very important to them. Social work support. We've learned we need to know how to get a hold of social work if people need help with housing, legal assistance if they're facing eviction or other problems. Here in Santa Clara County, there's a 211 number that goes to a kind of COVID command center where patients can go. It's one-stop place to get help with issues they're facing with COVID. We've also learned it is very important to ask about these social determinants of health, all the things that are going to affect their well-being. One thing I've learned, so I call people all the time. Hi, I'm from Stanford. I'm working the COVID-19 clinic, going to be talking to you today. They've never met me before. They're scared, they're anxious, and I'm calling them and I'm asking them, who do you live with? How many bathrooms do you have in your house? All these things. So what I'd like to do, and I encourage you to think about as well, is recording some personal details, the name of their pets, their kids, their parents, who are they living with? And every time I call them, I check in. And in reality, you're not just taking care of the one patient, you're taking care of someone with COVID-19, you're taking care of the whole family. You're trying to figure out how they cannot give it to their family members, but also make sure their family members who very well may be infected have access to care as well. So this is an actual cut and paste from the note templates we use in my Crown Clinic when I'm talking to someone when we're doing what we call the intake. This is just the social assessment. And this has exploded. When we first started, our note was, are you homeless or not? Do you smoke? And that was it. It has absolutely blown up. And we've done this based on feedback from patients, from questions they ask, issues we're realizing are important to them. All these slides are going to be available to you. I'm not going to go over every single one, but I think it makes you realize it's really important. You really want to do a really detailed social assessment, know a lot about what their life is like. In the very beginning, ask them if they want you to follow up with them. Make sure you have the right phone number. Ask them their insurance status. Sorry, not their insurance status, their language, what they prefer. It's okay, we'll get you an interpreter. What language you want, not a problem. We ask a lot of things about the resources that they have, if they need help with social work, and a lot of things about what their living situation is like. So we know how they can selfily help isolate. Patient education is a natural fit with health disparities. We do not have a cure for COVID-19 yet. I can't give patients a pill. The best thing I can give them is knowledge so that they can take care of themselves. There are challenges. I don't always speak the same languages as the patient. People have varying literacy levels. They learn different ways. Some people know a lot about COVID. Some people don't. There's a lot of misinformation out there. So what are we going to do? Don't get discouraged. There's a lot you can do. The number one thing is individualize it to the patient. Ask them at the very beginning, what do you want to learn about? And how do you want to learn? Ask them about language. How do you want to communicate? You want phone? You want video? Do you like email? Do you like paper handouts? And don't assume literacy. Whenever you have handouts, try to include photos and diagrams so that people of low literacy can access information as well. I'm going to talk about language really quickly. This is a breakdown in our Crown Clinic 56% of our patients speak English, 39.6% speak Spanish, and we have a smattering of other languages. If you are making handouts, I encourage you from the very beginning to offer them in more languages than English. I encourage you to match the languages you're providing it in, obviously, to the needs of your community. You don't have to guess. This data is available on the US Census website, breaking down by county, the most common languages spoken. And then after you've done that, if you're able to, track your patients and see if the patients you're taking care of match that breakdown. For example, in the Crown Clinic, we followed the Santa Clara County reported languages, the top 4: English, Spanish, Vietnamese, and Chinese. So we have handouts in all those 4 languages. As you can see from our breakdown, Chinese is not even on the list, but we actually had 5 Portuguese speakers. So you can use that data from the US Census website, going by your county, to start out providing those handouts, and then individualize it further for your own individual setting. This is an example of some of the handouts we do. So we do have a grant, so patients who are high risk, we can actually give them a pulse ox, and we give them a handout, how to use it. This is available in English, Spanish, Chinese, and Vietnamese. And I actually had someone tell me on another healthcare provider that they didn't think the Spanish patients could know how to use a pulse ox. And I was like, are you kidding me? We give this to all this, we have this language, this handout in multiple languages. And whenever possible, we have photos. And it's very simple. You push the on button, you put your finger on, you get numbers. I've taken care of hundreds of patients. Every single one of them has been able to figure this out, regardless of language or literacy level. People may not be able to read, but they can read to the numbers. Have, as much as you can, photos and diagrams on all of your handouts. And I think Alejandro, some of the handouts that he showed were great examples of that. So when you're talking with a patient, what do you want to talk about? Number one, whatever they want to talk about, what their primary concern is. They might want to know about what the different tests are and what they mean. That's a big question we have. What does this mean? Am I contagious? Am I not? For how long? One of the things I spend the most time on is really talking with them, as we talked about earlier, figuring out how to prevent giving it to other people. I also encourage you, one thing we don't think about enough is explaining to them public health tracing and notification. Important to tell our patients, if you have not gotten a call from public health, you may get one. They're contacting some of our patients who test positive for COVID-19. They do this, they can figure out where COVID-19 is and help prevent it from spreading to other people in your community. Understandably, there's a lot of distrust and mistrust. You get a call from a random phone number, someone's asking you questions, it's the government. Public health contact tracers have a really hard time in their job. And by educating people up front so that they're more willing to talk with public health when they call, can be a big benefit. So obviously people want to know, what do I do to stay healthy? How can I prevent getting sick? At this point, we don't have a magic pill, but there are things people can do. And I give them homework. I tell them to do things. And I don't think I'm being mean. By giving them things, I'm restoring people's sense of agency. And they feel better that there's things that they can do. First of all, I tell all my patients to move. Early on, almost all my patients with COVID-19 had back pain. They were sitting in their room, in their bed, all day long. In addition to causing back pain, we know that COVID-19 increases your chance of getting a blood clot, and that risk is further increased by inactivity. So I tell all my patients, if you have a phone, you got a clock, you got a timer, set your timer every hour when you're awake. I want your alarm to go off and you got to move. Do something you can do. Walk around, dance, do Zumba, do squats, whatever you want to do, you got to move every single hour. It helps prevent blood clots, it helps prevent back pain, and it gives them something that they feel like they can do. I talked earlier how I ask patients if they have access to the outdoors. And if they do, obviously I want you to be able to get outside safely without infecting other people. But if you do, every single day, I want you outside in the sun for at least 15 minutes. Patients are so happy when they hear this. They feel like they're stuck inside, and they are. And to be honest, being in isolation is like being in solitary confinement. It causes a great deal of anxiety and depression in patients. I know that getting outside, getting sunshine helps your mental well-being. It also activates the vitamin D, the levels of D3 in your skin. We know that low vitamin D levels are associated with worse outcomes in COVID-19. It has not been shown that taking extra vitamin D pills helps, but having higher vitamin D levels does. So this is one of those things that may help, definitely doesn't hurt, and it really helps my patients' mental well-being. Proning, or lying on your stomach rather than your back when you're resting or sleeping, helps your lungs work better with COVID-19, given the areas of the lung that it affects, and can help people with that symptomatic shortness of breath. Also important to directly counsel people to continue your usual medications. I have many patients who stop their usual medicines, worried it's going to make COVID-19 worse. And in fact, if you have asthma, the best thing you can do with COVID-19 is to continue to control your asthma. Same thing for diabetes and high blood pressure. So specifically encourage people to continue taking their regular medications so they don't stop. I spend a lot of time educating people on symptoms, what to watch out for. Obviously, if you're extremely short of breath, if you're passing out, you have bad chest pain, come on in. As many of us know, we see something we call silent hypoxia in COVID-19. Patients can have low oxygen levels and not feel short of breath. This is because, given the way that COVID-19 affects your lungs, your carbon dioxide levels will stay normal even as your oxygen levels drop. And that carbon dioxide level is what makes you feel short of breath. So people don't feel short of breath and they come and we check their oxygen level and it's in the 80s and it's emergency. But what patients do feel is they feel really tired with exertion. I've started asking people, and this is something I have made up, what I call the shower sign. If I ask patients, when did you last take a shower? And if they tell me they're too tired, they tried to take a shower and they had to sit down after a minute, I tell them, you have to come in. I've had so many patients who've told me that who've turned out to be hypoxic. A lot of patients want to talk about, and we want to talk about them as well. Again, we want to prevent them from spreading the infection. When can you go back to work and when can you stop the quarantine? We address that at the first visit. We talk about when they can go back to work and when we can get them a work note, and address that from the very beginning. That's really important to a lot of people. We also want to talk with people about the possibility of reinfection. There have been a few cases reported of people getting COVID-19 a second time. We don't know how often it is or what your risk is, but we do know it's possible. And I don't want people taking unnecessary chances. So I tell everyone with COVID-19, don't assume you're immune. You're not Superman. You're now, okay, it's been 10 days. You can leave isolation. You can go out, but you're like the rest of us. You got to wear your mask. You got to wash your hands. There is a possibility of getting chronic symptoms. That's in the news a lot. We're still learning a lot about it. Most people don't get chronic symptoms. Some can. Tell people, don't worry. I'm here for you. We're going to support you and figure things out. Retesting, usually not indicated. A lot of people will ask you if they need to be retested. We know some people will be positive for months and not be contagious. The nasal PCR test is so sensitive that PCR test will pick up tiny little bits of virus, even if it's completely not contagious anymore. So we don't usually recommend retesting. And then return to play, I want to address as well. Return to play is something we maybe don't think about a lot of times, but if someone's an athlete, we do want to think about that if they've tested positive for COVID-19. There have been case reports of people getting myocarditis and arrhythmias from COVID-19, including athletes. So ask people if they do sports, if they're an intense athlete, tell them they've got to take it easy until they're cleared to return. If they continue to have symptoms, cardiac symptoms such as chest pain or palpitations, if they're higher risk of getting heart disease, such as given age, history of atrial fibrillation, diabetes, or hypertension, or they had moderate or severe COVID, they should get a cardiac workup before resuming play, which should include an EKG, an echocardiogram, and a troponin, and possible cardiology consult. Other questions you're going to be addressing, especially looking ahead, is answering questions about vaccine safety. Vaccines are coming out. They've been developed very quickly. There's a lot of questions around them. For those of you who maybe don't trust the national or federal government, one good news is that California, Gavin Newsom, has made up his own advisory board, vaccine advisory board for California, comprised of multiple experts in infectious disease, epidemiology, healthcare differences, pediatrics, vaccine safety, and others. Those experts will be looking at the vaccine themselves and deciding if it's safe before it's released in California. So it's an extra layer of safety. One of the experts on that board is well known here at Stanford, Bonnie Maldonado, and she is fantastic. So I have a lot of faith in that board. So in summary, obviously significant disparities in COVID-19 exist. There's a lot of reasons. Many of them we can address. It's not genetic, it's things we can address. It is important to ask patients what they need. And I'm going to give a little example here. I had a patient who's new to our COVID-19 clinic. And my nurse came over and said, Dr. Barman, can you call this patient? I don't know what to do. She needs to know how to walk her dog. I said, okay. So I called her. And you might think it's weird, as a doctor, I'm going to be the walking your dog expert. But it turned out she was a young woman who had just moved to California for a new job, knew no one here, had a history of anxiety and depression, was diagnosed with COVID-19, was on the verge of a breakdown. Her only social support was her dog, Baxter. And she lived in an apartment. She had to take him outside to walk him, but she didn't think she could go outside to walk him because she had to stay in isolation. She was terrified she was going to have to give Baxter up to a shelter and she'd be completely alone. So I spent my entire visit with her was figuring out how she could walk Baxter. I said, okay, let's start. So walk me through, I'm visualizing where you're living. Walk me through from when you leave the door, when you leave your apartment and close the door, every single possible path to get outside. Okay, you're going here, the hallway, is it inside, is it outside? How many doors do you have to go through? The stairs, are they enclosed? Are they non-enclosed? Are you going through a public entryway where there might be a waiting room or a lobby people are in? Figuring out every possible way. And we figured out there's actually ways she could go at the back of her apartment, down a hillside, around a parking garage, but avoiding other people and access a patch of grass. So she could continue to walk Baxter to use the bathroom and continue to keep him at home. Now, again, maybe that seems like a weird thing for a doctor to do, but that was the most important thing for her. I called her the next day, and the difference was night and day. Mentally, she was doing so much better. That is the best thing we did for that person. So that's just an example. Ask patients what they need, and don't feel like you're above meeting those needs. Patients are very unique. Personalize their care. Everyone's challenges are different. Education is essential. The best thing, like I said, we can give patients with COVID-19 is information and meet the patient's needs. Thank you very much for attending this webinar. I just want to acknowledge I have an absolute fantastic team here at Stanford, as Alejandro does in East Palo Alto. We are all in this together, and I wish you the best. Thank you.